So we are recording. I'm going to go ahead and get started. We'll probably have folks that are joining us. There's another lady that's joining us. If you can just go ahead and type your name, your instructor into the chat box. All righty, you guys, let me back up. Professor Jennifer Harrison-Hauer, this is exam 2. I'm just going to get right into it. I do have a class right after this, so I'm going to be wrapping up things at promptly quarter till the hour. I put this little PowerPoint together. It doesn't include everything. You're going to have to do some things. Your chapter, make sure you read your chapters, understand the questions that they usually ask in the beginning, you know, the concept questions. The review guide I think is excellent. That you're going to probably see some math, so keep that in mind as well. But I'm going to jump right into you guys, some folks that we're admitting. Go ahead and I believe Ms. Floyd, and type your name and your instructor into you got Price into the chat box. Okay, let's go ahead, you guys. I want to make sure, save your questions for the end, please. It's not that many slides, but I think these slides are very important to your life. So here we go. All righty. For exam 2, what I'm going to let my class know and everyone know, I want you to come in to the exam thinking you are that community health nurse. You are that individual that's taking care of whoever's in that scenario. That might help if you actually like put yourself in that particular role. So then chapter 3, what I love about chapter 3 is that it really kind of delves into the vulnerable population that the community health nurse is going to likely going to encounter. All right, so they talk about rural health and migrant health. Your chapters delve into poverty, homelessness, and teen pregnant health, pre-pregnancy mental health, alcohol and tobacco. So when you think about a vulnerable population to begin with, you want to say to yourself, like, okay, so why is that important to me being a community health nurse? These are subgroups of the population, or groups of people that are likely to experience some type of adverse negative health outcome due to where they live, due to their economic status, due to the environment. So then you want to, if you're working with in rural health, okay, so I work on a reservation, which is a couple of hours from the nearest everything. So they're at risk because of their, the environment in which they live, the lack of resources. And so you want to, when you come in working with these groups, you got to think, okay, what can I do from a primary standpoint to make sure they don't get anything? What can I do from a secondary standpoint? What can I screen for or look for? And then if primary and secondary fails us, then we move to tertiary, and we want people to live as long as possible. So let's delve into each one of these vulnerable population groups. Things that are highlighted and bolded are very important for you to remember. So then your migrant workers, okay, first of all, the type of work that they do with the repetitive movements, the bending, the lifting, the bending, the lifting, the twisting, the lifting, that's repetitive movements and bending and lifting and what have you. It really does put a strain on their musculoskeletal system. All right, so you'll see a lot of conditions and injuries related to the musculature, the spine. So then you want to aim your preventions at that, maybe teach proper lifting. You can always educate. You want to stay in primary. Another thing that's really, really, really important to keep in mind is that their greatest risk for something is all these pesticide exposures that they come in contact with just from their daily job. So then if you're looking at it, because I want you to come in as a community health nurse, and let me just back up. We share our slides with all the other professors, so you should get you should get a recording. So Professor Price did her last night, and I'm sending it to my group when I wrap mine up. So everyone that has reviews, we share with all the other instructors. So I would, you could take notes, but you're gonna see this again. So you can listen. I don't want to say listen, you can do what you want to do. All right. So like if you're a community, I'm just saying that you should get this. Who's your Miss Folks? I got my screen minimized. Who's your professor? Jenny? Who?
Price.
Price. Okay. So I got hers last night, and so I'm sending it to all my folks. Okay. All right. So you guys, she's good about getting you guys your reviews, right? The recordings, you get the recordings from exam one from other people?
Yeah, she posts them. I just like to listen and take notes. It just works.
Oh, you do you. See, I disrupted your role. Let me get back. So from you do you. So so if you're thinking, I'm a community health nurse, I work out on one of the farms. We have migrant workers in Arizona, one of the border towns, so they work on a lot of the remote, we have farms out here, believe it or not. So then education on reducing exposure. So that's a primary example. So they never even get exposed to it because you're teaching them how to not get exposed as much as they can. All right. And then secondary, if you're noticing a lot of folks that are having pesticide exposures, then you can screen. So secondary, I teach my classes the 3 S's. If you want to think about screening, surveillance, and what is that? Screening, surveillance. I can't even think of the second one. Screening, surveillance, and surveys. And when we go to the doctor's office, in the last 3 weeks, have you felt like you wants to die? In the last month, how many have you had to drink? So they're screening you for certain things. And then tertiary is where we as community public health do not like to live. But then if they do end up, then you're vulnerable because they're vulnerable from the jump. Okay. So then if they mess around getting tertiary, their adverse outcomes are just not cute compared to everybody else. That's what you're trying to not get to. So if you're seeing a lot of skin irritation, nausea, remember you're nursing, so you got to do what's in your control. You get folks into treatment, you get them, that's tertiary. Tertiary means you have anything you do after somebody has a disease is tertiary. So that's why I try to help my class remember anything after. So if they have diabetes, if you see diabetes on the test, they have diabetes, so you're tertiary. So if you have a group of diabetic folks and you teach them about checking their sugar, yeah, you're doing education. You're going to always educate until the day they die. Even if you're in hospice, you're going to educate that their breathing is going to be shallow and stuff. And so then that trips people up because they're educating. Well, you're going to always educate. But if anything after they have a disease, obesity is a disease, addiction is a disease. So if you see that on an exam, it's too late, they're in tertiary, and you're just trying to make sure that they live longer, happier lives and all of that fun stuff. And so then rural health, again, these clients are they're less likely to participate in like leisure activities. They don't have the time. They on the farm from sun up to sundown. And so for this particular side, the most important thing you want to remember is that children are the highest risk group among rural health folks. That's very important to remember. My dad didn't even finish elementary school. They took him out in the 3rd grade. My grandmother had 16 children. I was telling somebody I was from Florida. My dad's from Georgia, so we're on that Bible Belt. They worked the farms. They made the kids work the farms. So they're the highest risk group. They're children and they're on the farm and they probably eating right, doing and getting their well child visits and all that. Decreased compliance with safety. All that means is that there's no seatbelts on the tractor. I don't know. I haven't been on a tractor, but no leisure time, like I stated before. And another thing that's really, really important to remember that everybody knows everybody's business in a small town. So like they don't go up to the clinics because they probably don't like that family member or that person gonna go back and tell their wife or all this kind of stuff. But children are the highest risk group. So that's the important thing slide to remember. Now we're going to get into another vulnerable group that your chapter talked about, and that is your Mexican immigrants. So straight from your chapter, it says that this vulnerable population, they see nursing, because we're nurses, you will be, as the authority figure. So that's important to know. All right. That means they have respect for the individual. You know, you can tell them anything, you know, okay, nurse, okay, nurse. And then you want to, with anybody, but again, we're talking about Mexican immigrants, you want to approach them respectfully. You want to respect everybody's culture. But this particular group, the chapter talks about, they don't want you, they want to sit down, like before this guy was doing his dressing, he needed to establish a rapport with him, chit chat. That's another thing that's, believe it or not, important. They don't want you to come in and just go bam and start doing stuff. They want you to chit chat, establish a rapport. Touching shows caring. So this group, they actually want touch. You know, you ain't got to go, you know, give them a bear hug, but you know, that's something that your chapter talks about, where again, some cultures, you better not put a hand on them. It's disrespectful, but that's something to remember. You're the authority figure. Respect, respect. Take your time before you even get into why you're there, not hours, but establish a rapport. Touching shows caring. So like how, you know, he may have just touched his knee or that sort of thing. So that's this vulnerable population. And then we're going to get into homelessness. So homelessness, oh my goodness, where to start? The whole point is that they have the same challenges in those in poverty. And I know it sounds like, well, you know, if they're homeless, they're in poverty. Yeah. But then they're homeless and they're in poverty. So it's like double, if that makes sense. You can be in your house and be poor, but at least you got a house. So then they're obvious, they lack money, they lack insurance and transportation, stability. Healthcare, ER is their home for minor or major things. But for this particular slide, what's really important to remember is that, again, families with children are anything bolder is very important to remember. They're the fastest growing homeless population. And I have seen it, folks that are homeless with their family. And I'm not going to get to the high housing crisis in the United States and all this kind of stuff. But if you're homeless by yourself, that's one thing. But when you're homeless, you got kids. And then like delving deeper, pregnant and homeless, okay? Pregnant and homeless. So then you're like two people are homeless, or if you got twins or what have you. That in itself, you need a village approach. And that's what in my class, I talked about, like the nurse family partnership and different things. But the point is that what's important to remember is that, believe it or not, per the chapter, they have a higher rate of STDs, of addiction, of poor nutrition. And then the dangers of being homeless, again, for mom and baby, again, there's two individuals that I think of it as like a family, what have you. So then you want to be aware. All these things are telling you is that for this vulnerable population, if you're working with pregnant and homeless teens, you just know that these things that are associated with them. So then if you know that coming in, you know, this is just some FYI, you're going to already work on STD screening. You're going to already screen people for addiction. You're going to always try to get people into WIC, women and children. I'm just running my mouth at this particular point. But for this slide, homelessness dangers are for mom and baby all around. You want to get them into services. And there's stuff out there. People don't know because they're homeless. They're trying to find the next meal. Now I'm going to get into deeper. And we're talking about pregnant teens. So pregnant teens, there is an increase in single motherhood, period. I am a single mom, but I have more degrees than a thermometer. I'm, by the grace of God, I'm doing good. But single motherhood is increasing, especially among teens, all right? So if you have a pregnant teen, bold. You need to make sure she stays in school. She needs to be in school before, she needs to be in during school, after school. There's, we have a teen high school called TAP. I think it's all over the country, major cities. But for this slide, what's really, really important, is the association between, so she's pregnant teen, okay? So if you already know that if she doesn't have education, lack of education for anyone, they say is associated with poverty. And then poverty, period, is associated with poor health outcomes. So you want her to stay in school. So she gets her education. So I think it was flip it around. She stays in school, she gets her education, she won't be poor, and she'll have better health outcomes. All right. They need to stay in school. I don't know how else to say it. Keep her in school. Keep her in school. All, this is in capital bold. All pregnant teens are at high risk. I don't care if they're the Cardassians, because being pregnant in a teen, you're still growing, you're still developing. I don't care if you have a little money, I don't care if a lot of money, your body is still your body. So then again, limited self-care is associated to pregnant teen moms, poor nutrition. I mean, if I see, I'm a nurse, women's health nurse practitioner. If I see another woman come in with a bag of toffees, I'm going to scream. They're still growing. The bones are still growing. The uterus probably still growing. Everything growing. And they tend to have limited finances. Now let's flip script and let's go to addiction. Again, this is your chapter 26. So addiction, to begin with, what is that? It's a pattern of abuse. They're abusing a certain drug. All right. They're so preoccupied and fixed on getting that drug and securing that supply by any means necessary. Okay. So then these are things, again, if you end up being a community health nurse and you're focusing on addiction is your subpopulation, you already know they're vulnerable. Okay. They're vulnerable because of their addiction. That puts them at their vulnerability, whether they have a little money or a lot of money. I've seen people in expensive Armani suits just jacked up. So, all right. They're at a high relapse if that drug is removed. So you already know that. You already know that. There's the physical and psychological dependency that you need to be aware of. Withdrawal symptoms, preoccupation with getting that next drug. Just know that it's not just physical. You don't have to memorize certain things, but just know there's physical and psychological dependency. They can have one or both. And then they're at a high risk for harm too. So knowing that addiction brings all these things that's listed on the screen, these are things for you to be aware of so you can focus on. Remember, addiction is tertiary because they have an issue. You can't primary it. It's too late. You can't screen for it. We already know they're addicted. So anything you do after somebody has something is tertiary. And so the tertiary, what you're trying to do is keep them from, you see that person on that screen, y'all seen Euphoria? Put her in your brain if you have an addiction question. I finally got around to watching that. Believe it or not, like a couple of months ago, I could only do like a couple of episodes. I'm still messing with season one. It's just too much. And then I look at it, I'm like, how can you be Spider-Man's girlfriend? So I have to stop. No, really, I'm not even playing with y'all right now. I'm like, so then when I did this PowerPoint, I just put her in like, I have to, for me, I'm like, just if you get an addiction question, think of that person that's on this slide and you should just be just fine. She's a slick one. I'll give that to you. She's a slick one. Now let's go to something completely different. We're moving to professional negligence. When you guys see anything about professional negligence, I want you to think about your role as a nurse. I don't want you to worry about other people. When we want to know, make sure that you understand as a future nurse about professional negligence. And so when you think of negligence, you think of what your failure to act or do something that leads to harm. Your act or not acting, people don't realize what you do as a nurse or what you don't do as a nurse, and leads to injury or can lead to injury, okay? So then I want you to consider, when you see the scenarios, you want to think about the nursing aspect of it. You don't think about what other people, you want to think about you and your professional role. Just remember that, okay? I don't know how else to say that without saying that. So again, if it leads to an injury to a client, to a patient, they can sue you and get money in a malpractice action. So nurses can be part of a lawsuit. They have to prove that you, as following, that you had a duty as a nurse, you had a responsibility for that person's care. So that's number one. And if you're working with that client, that patient, you are, because you're assigned to them. And maybe some other people are assigned. And it's not like you want to be the only person named in lawsuit, but you will be named. And then you had a duty as a nurse to perform an act in a reasonable way, because you're a nurse and you went to school, you took tests and stuff. So you're supposed to know certain things and you didn't do it. You didn't fulfill those. You didn't act reasonable, and it led to somebody being injured. And then because of those injuries, they can ask for money for it. And so I don't think I need to go into like examples or what have you, but let's just say somebody got their wrong leg removed. But you want to, so where was your role in all that? Don't worry about the doctor. Worry about you, what you were supposed to do. All right, it's busy because I was trying to get everything on one slide. So these are important agencies that you need to understand. So World Health Organization, I think of them as the CDC for the world. So if you understand CDC, that might help you, but people don't realize, because I know we give you a lot of stuff to read, but they do a lot of things. They want everybody in the world to be healthy. Okay, that's wonderful. But they also, people don't realize, they monitor drug reactions. Everything that's listed there, they share their research to the world. Okay, that's why it says world. They collaborate with other countries, not just the United States. People think World Health Organization, United States. No, they work with people in Uganda. They work with people in Switzerland. So everything that's listed there, you need to know that's what they do. They do everything. All right, because they're trying to keep the globe healthy. And then the Agency for Healthcare Research and Quality, you may say AHRQ. So these are the folks that come up with quality indicators. So quality indicators, let's just say you're a hospital administrator and you're trying to see how you're doing with the quality indicator. So quality indicator could be like, how many bed sores do you get? How many folks have, I don't know, have, restraints or something. And you want to compare that. You want to look and see, okay, are we doing good with that quality indicator? I said, oh, wow, our bed sore rate is at 5%, but per the Agency for Healthcare, it should be less than 0.5. And these are things that we can do. So that's something to keep in mind. So they're responsible for quality. And so think of them, use that word quality, all right? Their quality and safety. So actually, I teach another university, and so they have to look at this website, pick a quality indicator, do something, because you want to provide quality care. So you want to have a site you can go to compare how you're doing with a certain quality indicator. I used bed sores. Let's say you work in a nursing home and in hospital administrating, your rate's 2, but for the United States, they wanted to be less than 0.5 to be good with that indicator. So anyway, and then CDC, if I have to explain CDC, I don't know what to say. So Centers for Disease Control, they monitor the health of the United States. They detect problems early. They're the ones that was at the forefront of COVID, and when everybody know what COVID is. And so we were at work going to CDC a lot. They were going, as the disease was progressing, new standards for healthcare workers. We were looking at that, so we can say, per CDC, you need to stay home this, you need to do that. And then HRSA is Health Resources and Services Administration. They're the ones that provide, they help future healthcare workers. They help current healthcare workers with educate. I'm a HRSA recipient. They give me monies to go back to school, but I have to work in a rural area, and I already do. Or, you know, if you work at a certain location, if you're trying to, I think they have one they have grants and scholarships if you're, if you work in a higher education institution. So let's just say you work in a university, but you got to work at a certain university, sort of thing. So they help, they provide monies for folks to work in certain areas so that they can have more healthcare workers in those areas. All right. And then let me go into a little bit of epi stuff. So the epidemiology triangle, you wanna make sure you really get an understanding of let me get this out of your way, of what it is. And I've got another slide that's really, I'm a visual learner. Like, people can talk, but like I got to go back and look at it. So all the epi triangle is telling you is that in order for disease to occur and definitely to spread, you need a host, you need an agent, and you need an environment and balance. That's why they're all connected. If you can somehow break, and you'll hear people say, break that chain at any part, it's like, imagine three people holding hands, and you can somehow, they're holding it so tight and you're trying to break them apart, and you can't, but you got to, that's what you want to do. At any part, if you can break that apart, so you won't get disease. I know that sounds really simple. I have friends today, we work in the same place, and they never got COVID. Same patients, never, ever. Yeah, people that eat the same food, only 1 or 2 or 3 people get sick. That's something to think about with your epi triangle. So let me kind of delve into it. So then, your agent is probably the easiest thing to remember. That's your virus, okay? That's the thing. All right. Then you got your host. So that's you. Let's think of that as you. So then you have your pathogen, your virus, that's the agent. And then you have the person, okay? The organism who's going to be exposed to that thing. Well, all of that is wonderful and great, but the environment brings it all together, all righty? So it brings it all together, and then you have disease. So then page 155, I wrote this at the bottom for y'all, chapter 9, C box 9.1. So if I go into it a little bit deeper, all right, it gives you an example of the host. So again, it gets into the host more specifically. And I don't want you guys to get into too deep, but deep enough to where you get it. Because if you understand that host, the agent, environment, and you know those factors specifically inside the host or the agent, then you can work on one of those things or all of those things so that disease doesn't occur. So, but then, how do I want to work this? So let's talk about the host. So let me give you an example. Let's just say you have a host who has lupus. So her immune status sucks. So I'm working with the immune status. Hold up. Then she gets exposed to COVID. And she's in jail. So there's crowding. So all of those factors together, her having an immune system, that's why they were like, certain people need to get these shots first, 5 shots, 10 shots, 12 shots. No, you need 1, you need 2, you need 5 boosters, you need 8 boosters, you just need 1 booster because of specifically things going on with that host, their immune system, their occupation, health worker. So then again, if you know certain things about the host, the agent, for me, I'm just weird. After people get sick, I spray my doorknobs with Lysol. I disinfect the house so that I get that agent out of there. So I don't know if that's a good enough example or not. But again, that's if you wanted to, if you know that these 3 things have to be in balance for disease to occur, and if you could somehow strengthen that person's immune system, or if you can't do that, make sure they don't get exposed to the virus, the agent. If they never get exposed, then they ain't gonna get COVID. So then you got to somehow, if you know these things, and as a community health nurse, you need to, within your reason, you can't change somebody's genetic profile, you can't change somebody's race, you can't change somebody's sex, people getting older. That's why it's like, from the host standpoint, you know, really, the only thing I can see is if you can somehow make sure, like people with HIV, they're taking their medication so their numbers don't drop and their immune system doesn't change. And then not getting exposed to the agent would be your mask, staying sick when you're home, because nobody needs to be exposed to whatever you got or you think you got. That's why they're like, stay home. Yeah. Air pollution, all of that stuff. So that's where they're talking about breaking the chain. So if you somehow disrupt either one of those angles, or more than one angle would be best, then people won't get sick. And I know it sounds real simple, but I got COVID from my daughter coming home from school because I was masked up. I had these suits on, I had all this stuff. I never got sick. Never got sick. And then she came home coughing. You're not gonna wear a mask in the house around your kids. I should have. I was out for 3 weeks. Work didn't do it to me. And I work with vulnerable population people. Didn't do it to me. Because I didn't wear a mask at the house. How many people wear a mask at the house? Nobody. All right. Then this kind of gets a little bit more, you just need some stuff you just are going to need to memorize, period. It's not going to make sense when I say it. And that's fine, as long as you can go back to page 154, chapter 9, and make sure you understand these 4 terms. So with epidemiology, period, it's all about numbers. Numbers. These are the folks that give us the rates and tell us probabilities of certain things. Like if you get bitten by a rabid dog, this is your probability of dying, opposed to this, that, and the other. So then you have your attack rate, and it's simply a rate that people in public health use, the epidemiologists. So when you become a nurse and you one day and you hear these things, you're like, yeah, I think we talked about that in that class. At least you've been exposed to, and you won't be like, what's a who? So these are things that these terms that they like to use. They like to use attack rate. They like to use case fatality rate, okay? And it's used to predict outcomes. Again, afterwards, just go back and make sure you read page 155 again. And then they have cause-specific morbidity rate. So that's the death for a disease X. Let's say death for COVID in a specific population. So I want to look at death from COVID in my migrant workers or something like that. It's just all of these are just another way of looking at something. And if you work in epidemiology, you might want to look at an attack rate over a crew. You know which one you want. So you don't have to be like, what are they talking about? You just got to know the difference. I don't know how else to say it. This is pure, you're going to have to make the time to memorize. And then again, you wanted, like I said, you go back to page 154 and read it and understand the differences. So if you were to see it again, you know what the difference is. And then Medicare versus Medicaid, again, it's good to make sure that you know the broad difference between them. First of all, Medicare is federal, all right? And Social Security administers that. It's a federal program, 65 or older or disabled, okay? What's important for this slide to know is that for Medicare to pay for skilled services, they have to have a need. They're not gonna babysit your elder grandmama and she don't have a need and one of y'all can stay home with her. She's gotta have some type of skilled nursing that you need to be out there for. It's not babysitting, they must be homebound. There have to be a need for skilled care. Did I say that right enough times? Medicaid, I like to think of it as a Band-Aid. It's based on your lack of financial resources, okay? It's a it's a program that's administered by the state. So one is a federal administered program. So that means if you want Medicare, you got to go to the Social Security building. And then every state has, in Florida, it was just called Medicaid. Here in Arizona, it's called Access. It's still Medicaid, but they don't call it Medicaid. They call it something else. And Access is an acronym from Arizona, blah, 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 blah. But anyway, if you want to apply for Medicaid, you don't go to the Social Security building, you go to wherever your building is. And the differences between the two that's really important to remember is that if you're trying to get skilled care under Medicaid, it's a little bit differently in a better way, I guess, because it doesn't require you that you be homebound. Both programs are different. They have their own rules, but it's good to know, because if you have a client that has Medicare and the daughter's like, I wish Medicare would pay for somebody to come and just sit with mama. No, you got to say that nicely, no. And so that's where your home reimbursement for your home health aides come in for non-skilled services. And then keep in mind that, see, again, I'm visual. So for me, I would just go back to the slide and just like, look, because you can do both if you qualify. So you're like, does mama have Medicaid? Oh yeah, I forgot. Well, then let's see if we can get some home health, get somebody to come out and wash her dishes and do something like that and sit with her. But Medicare is not going, Medicare is to care for you. Medicaid is like a Band-Aid. I don't know. That's how I always thought about it. And so where these two circles merge is that both of them are both of them have a section to where you can be low income and disabled and cannot work. That's where that's the commonality with the dual eligible part of it. So I know folks that get both, but if you're 55, don't even about it unless, again, you have something else going on with you. All right, so now we're going to switch into our hospice care. So for folks to be in hospice, in Florida, you had to have a terminal diagnosis of less than a year. I have known people to be in hospice, do better. It's been a year and a half, they get discharged and they come back, maybe not. You can be discharged for, but it's end of life care. So in that in mind, you're providing dignity and comfort as they are transitioning. And so pain management is really huge along this, because you may see cancer patients or folks that are uncomfortable during this. But the thing about it is that sometimes there's family dynamics that come up with how to care for mama and what to do in that. And so I put that in that you're not only, taking care of the patient as well, and you want to make sure that their wishes and desires are met, but you got to work with the family, encourage them, communicate with them, work with everybody there, and realize, again, you're educating on what to expect and see and why you're not giving them an IV because they can't sip water. You need to explain all of that while their skin is turning a slightly blue, while they're breathing kind of different. all of the, so you're still educating, but you are, please don't say primary. It's the epitome of tertiary at this point. So you never stop educating on what to expect, what to see, you know, and as mom and or that patient gets closer towards the end, you know, folks, you know, feelings come out, people being their feelings and stuff. And so you're all right, Miss Janae? You good? Yeah, people get all up in their feelings and stuff and family and what they should have done, didn't do, all this stuff. So curing the disease is not the goal, and they need to know that as respectfully as possible. So then your parish nurses, okay? So your parish nurses, what's important to remember are these three things, just these three things. But of course, page 511 in your chapter 29 is also good too. Most of these nurses and parish nurse, school nurse, they are autonomous, which means that they have the skills set to work, and they work independently. That's what autonomous means, okay? That's because they are able to, because they have the skills and they have the training to do that. They're over a congregation, all right? They're assigned to a congregation, all right? And it's usually, it doesn't have to be, but it started out in Christianity. But you need to know that they follow the congregation-based model, all right? And the congregation-based model is literally is that they are governed by a congregation, a ministry, or what have you. But there is a congregation-based model. That's what they follow, all right? So that's really important to know, like, what model do they, they follow the congregation model. And then ecologic study designs, I need to talk faster. All right, so again, these are page 164. Ecologic, again, this may not make sense to you right now, but this is another slide. You're just gonna have to memorize the difference between them and make it make sense to you. So then ecologic, think they want to look at correlation between things like people that smoke, parents that smoke, and then children, the rate of children that are getting asthma. Case control literally means that whatever you're looking for designing, you have somebody that has a disease, which is your case. Let's say people that have COVID and people who do not have COVID. And you're looking at, that's why they found out that loss of taste, this, that, and the other. They were looking at the cases and the people that didn't have it. Okay. And then cross-sectional, I think of it as taking a slice in time. All right. You're looking at cross-sectional. When you hear that, just think of prevalence. Prevalence means existing cases. I'm sorry, not existing. Yeah, existing. That, let's just say they're looking at a cross-sectional of diabetic folks, and they're looking at a certain time frame and looking at different behaviors and lifestyles and that sort of thing. Retrospective is probably the easiest one because you're looking back in time. So you're going back and you're viewing, I don't want to say chart review, that's too simple, but you're going back and you're looking at diseases that's already occurred. So they're doing a lot of retrospective stuff with COVID, I'm quite sure, or let's say Ebola outbreak that they had. And they're taking those past cases. They're going, usually they go through people's hospital records. They're looking back in time to see what's already occurred so they can gather that information as well. But go to 164, just read that one again, all right? And then your occupational health nurse, again, she's autonomous. You can see that lady in that screen, she got it. She's got it taken care of the health and safety of the employees that she's responsible for. Parish nurse is that church. Occupational health nurse, there's IBM has one. They make lots of money. Most of these large plants have an occupational health nurse. They want to keep those employees healthy and safe and at work so that productivity doesn't go down. So if you're looking at it from a primary standpoint, like what they do, you want them, again, think of that migrant nurse, community health nurse. They want to help them teach them how to properly wear their stuff, educate. so they don't get any harm with certain equipment, because they taught them, you got checked off on how to put this on and use this thing. And so you're checked off on that. So primary. Secondary, you're screening for disease or detecting something early. So she's doing blood pressure. Blood pressure is a screening, believe it or not. And then tertiary, so anybody that's in tertiary, if they've had an accident, something's happened, God forbid, then she's working with trying to get them restored and back to work. Because that's what she's assigned for. She loves the employees, but she got to keep people at work. And then your OSHA, your Occupational Safety and Health Act, came back in 1970. But the point is that I want you to know that the occupational health nurse, she lives in OSHA land. Like that is the agent, that's her CDC. All right. So she's looking at OSHA standards, just like when we're at work, we're like, CDC says this, CDC says that. But then she's responsible for making sure that she's upholding those occupational health standards for OSHA. And then they have a database, just like CDC has a database, so they can report stuff. So that's where she's going to for her information. And then a little bit about environmental health. What's important to remember is that I know it seems like occupational nurses do everything. I mean, not occupational, community health nurses, but there's always little things that you can do, and realize you don't have to do everything yourself. But just touching on environmental health, if there's, they're working with, again, this is my environment. Where you live is your environment. Everything that's outside is your environment. The air quality in your house, inside, outside, everything that's affecting you externally. So if there's one thing that you can teach folks to do, that's really simple, is to reduce their consumption, reduce, reuse, recycle. Just remember that. Reduce your consumption, reuse, recycle. It's simple, easy stuff that you can teach folks. Even if you're a homeless client, you can teach them. All right. I mean, they may not be thinking that, but you can. And so that concludes our exam 2 review. I will make sure that I share this with your class, and I'm going to conclude now. Professor Harrison-Hauer, exam 2 review, August 11th. Thank you guys for joining me. And